Steve Lipshultz. Lessons learned. I spent most of the last 35 years looking at the first generation of survivors of a lot of formerly fatal illnesses of early childhood. So out of necessity, caring for these survivors, we've had to look at ways. Originally, people were told that, an early in life exposure to potentially a strong substance, you're either going to have an acute effect or you're going to be free and clear and good to go. When we started seeing late effects after transient early exposures, it really pointed out that we really don't know when safety signals come up, who's at risk, what's the percentage, what's the degree of severity. And so over the last 35 years, we've really looked at this in childhood cancer survivors for cardiotoxicity. 1% have the equivalent of, calling a poison control center with acute heart failure. It's the leading late effect many years after exposure, especially for those who were exposed early in life. We see the same thing for those that we followed now longitudinally for many years with early in life exposures to antiretroviral therapy to block transmission. We had a big paper this year on radiation exposure and 18 million patient years of follow-up, and we find as strong a signal in long-term after exposure, as you do for cancer, for heart disease, and I go on, but it's a recurring thing. So I take the approach beginning with the end in mind. So if you're saying safety signals suggest there may be a safety signal, at least at the clinically apparent level, in a vulnerable population, such as a child, well, that might be the tip of the iceberg. It might be true, it might be not, it might be important, it might not. We know in other situations, such as fen-phen and other things, certainly a more chronic usage pattern is associated from a cardiac perspective with changes. We have no idea in this case what the non-acute, more chronic effects are, if there are any, or what the profile is. So when I approach this, when I design these studies, when I follow them, and several of us invested a decade on National Children's Study, and I believe strongly that the appropriate study design is important. You can't a priori think of all the questions that you're ultimately going to want to know, and so the importance is having a study design. So you need really a good design. You need to really characterize. You got to let the patients and the exposed really direct what you need to know. And I usually approach it three ways. One, I have to understand the clinical course. It's killed me through the years, every 5 years, every 4 years, writing to the NIH, saying, you funded me for this cohort for the last 4 or 5 years. I want to continue to follow them. I'll never get funded. I have to come up with some crazy other reason to beat out other people. If you're going to say you're interested in lifetime exposure effects, you have to have a mechanism to have a cohort, follow them longitudinally and carefully with little missing data and with unambiguous and quantitative things. If you really have quantitative subclinical points, you don't need a 100,000 person study. You can get answers quite nicely. So one is understanding course. Two, risk factors, vulnerable populations. And that comes out of assessing it, whether it's doing whole exome sequencing, or whatever for genomic phenotype correlations, whether it's biomarker development, that's important. Third thing is, what I want to know is, are any of those vulnerable populations that I brought up theoretically today truly a concern? I can tell you my colleagues would never want to recommend some of the products we're talking about today to some of the vulnerable populations. So is that based on truth? No, it's based on clinical impression. So how do we go from clinical impression to understanding where the truth is? Only by longitudinally following these patients and really understanding. If you do that and you find that, there is a higher incidence of subclinical or later clinical issues, then if you've really collected biomarkers, you can then have the ability to determine whether any of these are validated as predictive of outcome. So early on, you can track. And so those are the three areas: course, risk factors, and biomarkers. They become important as you're trying to assess, is something safe, is it not? And And the conventional NIH mechanism for establishing these cohorts just doesn't fly when you're looking at really, it's one thing for me to present without safety signals for acute toxicity, and just as Amelia said, it may only touch the tip of the iceberg. As Christina brought up, it could be extremely biased in many ways. It's the best we have right now. So, if we really want to try to answer these questions, I don't know of any other way to do it. Then really you have people, you follow them carefully, and you look at course, you look at risk groups, you look at biomarkers, and then you have a well-characterized cohort. You can bring up all these questions. Is one particular set of combinations of supplements or other things more of an issue than others? Is it a combination? Is it an individual? Is it an age effect? Is it a gender effect? Is it an ethnicity? You don't know until you really look at it with a proper design. Thanks.